everybody. Thank you for joining us here today. My name is Fabiana Bacchini, Executive Director of the Canadian Premature Babies Foundation. CPBF is a charitable organization, and our mission is to support and educate families of premature babies. This Premier Chat series is one of the many initiatives we have to bring information for NICU families and healthcare professionals. Here every Friday, we talk with experts, researchers, and parents who share with us their experience and knowledge. Also on our website, canadianpremies.org, parents will find all kinds of resources and support. And today we're going to discuss research knowledge on the health outcomes of mothers and fathers of babies born preterm and explore ways to best support parental well-being. I have here joined me live from Toronto. Let me bring them to the stream. Here, Dr. Eyal Cohen, co-founder of the Complex Care Program in the Division of Pediatric Medicine at the Hospital for Sick Children, where he's program head of Child Health Evaluative Sciences in the Research Institute. And also Dr. Joel Ray, a senior scientist at the Institute for Clinical Evaluative Sciences, with research focused on obstetrics and gynecology, cardiovascular disorders, and ethnicity. He's also scientist at the Shing Knowledge Institute at St. Michael's Hospital in Toronto. Dr. Cohen, Dr. Ray, thank you so much for joining us here today. So I will start sharing your screen. We have a presentation to share with us. And for all of you watching us live from YouTube or Facebook, please send us your questions and your comments, and we will be addressing them at the end of this presentation. So let me start here. And here you go, Dr. Ray, you can start.
Welcome, friends. And I'll try to be very succinct and very focused, respecting the audience who's listening today and joining us. I'm going to talk actually very specifically about aspirin. The reason I'm talking about aspirin is it works really well in a very specific set of scenarios that I'll describe, things that can change pregnancy outcomes to a degree. It's very cheap, it's very safe, and has no known negative consequences on either the mom or on her fetus. And for that reason, I'm going to, in a sense, elevate the purpose of aspirin for an audience who has experience with prematurity and other aspects of family planning. So next slide, please. I have no conflicts of interest at all. Next slide. So when I think a lot about pregnancy, I think about the mom and the baby, and I think what connects them. And obviously there's something very beautiful and natural about the way a woman carries her fetus. But the placenta, this unusual organ, is the mediator to a big degree of how the mom and baby are connected to each other during the pregnancy. Next slide, please. And so if you can do a click, please, Fabiana. When we look at that middle box called placental dysfunction, what I'm really talking about is when the placenta just doesn't function normally. And that's quite a common scenario. There's different reasons why the placenta may not work well. But because it's mostly blood vessels, a big part of the placenta not functioning well has to do with the blood vessels on the mom's side or on the fetus's side of that connection, of that most unusual organ. If you can click, please. And so when the placenta doesn't do well, the mom can get high blood pressure, and that can lead to morbidity or an unwell mother because of elevated blood pressure and the complications that can occur. Next click, please. When the placenta doesn't work well, we can have the most unfortunate circumstance of a stillborn baby, a baby that succumbs inside the uterus while still unborn because it hasn't grown well, or because the placenta even separates prematurely from the wall of the uterus. Next click, please. If the baby is born very premature, we can again have the tragedy of a newborn death, which is another consequence of the things I mentioned earlier, poor growth or placental separation. And next click, please. And of course, if the baby is born alive, I'm sorry, it's just one more click, Fabiana. then the diseases of prematurity can arise where the baby is born too soon, not fully prepared for life, and for which many parents on this broadcast can, of course, relate to these baby issues and can talk, obviously, a great deal about them. Next click, please. And so preeclampsia, if you want to just do a series of 3 clicks, please. Maybe 4 clicks, thanks. Preeclampsia is high blood pressure. It typically arises after about the 5th month of pregnancy or 20 weeks. That's supposed to be protein in the urine, sorry for the spelling. And the mom can have a headache and unusual vision, pain in her epigastrum, which is just around the chest bone, and she can also have excess reflexes and even have a seizure problem because of this excessive high blood pressure called preeclampsia. Next click, please. Next click, thanks. You're welcome to keep going and I'll let you know. And so 2 clicks, please. So when a woman is delivered by her provider, meaning that she has to be delivered early by either cesarean section or induction, and we look at provider-initiated preterm births that occur between 28 to 31 weeks, which is quite premature. More than a third of them are from just the mom having preeclampsia. And for provider-initiated preterm births between 32 to 36 weeks, 22%, or about a quarter, are from the mom having preeclampsia. So preeclampsia is a big player in preterm birth. Next click, please, and then one more. And so a while back, we spent a little bit of time looking at how much being born early because of either a mom having preeclampsia or because a baby not growing well, how much those provider-initiated preterm deliveries might be preventable by an aspirin program in Canada. Next click, please. And so in a nutshell, the very bottom of the squares that you see, the 4, 4, 9, 5, is just simply the number of provider, meaning physician, initiated preterm births there were. And these are actually data for all of Canada for a couple of years. Next slide, please. And you're welcome to click again. We'll go to the next slide if you can. So it's a couple of clicks, Fabiana. Thank you. And next click. And so I reiterate this picture, knowing I've just told you quickly about some of the things that are potentially adverse outcomes or unwanted outcomes when provider-initiated preterm delivery occurs on the mom side and on the fetus and newborn side. Next slide, please. And you can click to the next slide. Thanks. And so you again can click, and I'll just ask you to do 3 clicks, please, Fabiana. Again, even. Thanks. You can keep going. And just really the top, that's great there. In the green, what we're looking at, and I apologize if the screen's very small, but this is just simply at the very top, term births, maybe meaning babies not born preterm, in which we've looked at how many of these births are affected by either PE, preeclampsia, IUGR, intrauterine growth restriction, where the baby is not growing to its normal size, it's small. And in the red, what we've got are the preterm births. And without hitting you with a lot of data here, what we know is that when both the mom has preeclampsia and the baby also has intrauterine growth restriction, the mom has a longest hospital stay in that state where both she has preeclampsia and the baby has growth restriction, and there is a preterm birth that occurs. If you click the next couple of clicks, please. When we look at the effects on the baby, please keep going. And we'll get up to the green. And so the red shows us, most importantly, that for the baby's length of stay, when both the mom has preeclampsia and the baby has growth restriction, we have a much, much longer length of stay for preterm babies in that dual situation than when the mom has no preeclampsia and the baby does not have growth restriction, which is the in that red box, the top dot. Simply a much, much shorter hospital length of stay. Next click, please. And so back in 2014, the Pre-Eclampsia Foundation, and you can click again, please, told us through a big survey of pregnant women that a whole bunch of women, about another click, please. More than half of women just didn't even know what preeclampsia was. And you'd say, well, they're not healthcare providers, they shouldn't know. But I would argue actually they should, because preeclampsia affects about 2 or 3% of all pregnancies, and its warning signs are translatable in a handout to women. And this is also a somewhat preventable condition. Next click, please. And so aspirin ends up being something worth advertising. And again, I have no conflicts of interest. The data, the science is what really has compelled me to push for aspirin in sort of the larger population. Next click, please. Thank you. And so when we have studies, you can click down. Thank you, Fabiana. And when we have women who we can identify as moderate or high risk for getting preeclampsia, next click, we have 46 randomized clinical trials, now more than that, with 33,000 women. Next click. And so when we look at the outcome of women getting preeclampsia, when they get aspirin or they get placebo being compared head-to-head in a randomized fashion in good quality studies, 46 of them in this case, we have about a 17% reduction in the risk of a woman getting preeclampsia. And that means that the number needed to prevent the NNP is 72 women getting aspirin to prevent 1 case of preeclampsia. And that's actually a pretty favorable number, because aspirin is so cheap and safe and low in side effects and accessible. Next click, please. And for perinatal death, which is the death of either the fetus or the neonate within the first 27 days of life, the number needed to prevent by giving aspirin to a woman at moderate, high, or high risk is 243 women to prevent a perinatal death. A terrible outcome for which aspirin can lower that risk to a degree. Next click. For having a baby that's small for gestational age or undergrown or growth restricted, 114 women at moderate or high risk would need to get aspirin to prevent 1 case of small for gestational age newborn. Next click, please. And next. Next click. And you can just click maybe 4 times. And really what I was mentioning about the safety is that we don't have excess bleeding in either the mom at her birth or with epidural anesthesia. The baby also doesn't have more bleeding, and the aspirin doesn't affect the baby's heart in some specific way. Next click. And so typically when we want to even further reduce the risk of bleeding, just in case, we can stop aspirin at 36 or 37 weeks before likely the baby will be born, in which the bleeding risk to the mom is even further reduced by stopping the aspirin in that timely way. Next click. And next click. And so we have 17 randomized clinical trials with 27,000 women, 13,500, and what we can get antiplatelet or aspirin, and the other get placebo. And please, next click. And for developing spontaneous preterm birth before 37 weeks, so this is preterm birth that actually occurs without a physician interfering by trying to deliver the pregnancy early, but just spontaneously preterm birth, if you can click. We actually have rates that with aspirin in red are lower than with placebo. Next click. And that's about a 7% reduction in the risk. And that may not seem like a lot, but this is for spontaneous preterm birth, which we almost wouldn't expect to have an effect. Next click. And for spontaneous preterm birth before 34 weeks, we even have a lower risk with next click, an even higher relative risk reduction, which is a 14% reduction in the risk for earlier preterm birth of a spontaneous onset, meaning without intervention. Next click, thanks. You can go on. What we wanted to do, and people have spent a lot of energy, is asking, so how can we identify a woman who's at higher risk? Next click. And next click. Next click. Thank you. And so just one more click. So we spent a fair amount of time studying this, and what we were able to do is identify a mechanism where if a woman has any of the conditions in that green circle, any one of them, such as high blood pressure before pregnancy, or prior preeclampsia in another pregnancy, or high body mass index, or diabetes before pregnancy. If she has any of those, we would say she gets aspirin. And in the orange circle, we require 2 of these features, which are things like having a twin pregnancy, or a prior stillbirth, or maternal age over 40 years. And those things could identify either 1 green circle or 2 orange circles, which women we could efficiently put on aspirin in the current pregnancy and start that aspirin by about 12 weeks of pregnancy. Next click. Next click. And just to show you, you're welcome to click a few here, Fabiana, that we ended up doing a study here at our own hospital. And what we showed, you're welcome to run through it a little more. Even more, thank you. Using that same set of circles, next click, is that if we used our circle approach and we said there were none or present of either 1 green circle or 2 orange circle features, we were actually quite good at being able to predict preeclampsia. And next click. And when we looked at sort of the number of features in the circle, what we saw is that the more features a woman had, the higher her risk of getting preeclampsia in sort of a stepwise or gradient manner. And so we felt we had a pretty good model for predicting preeclampsia overall. Imperfect, but not bad for practical use. Next, thank you. And you can go on. You're welcome to click past these ones. Thank you. And so when we ask what's the dose of aspirin, you'll see a little bit of debate that's out there right now, and you're welcome to click. We sort of spent some time, myself and a couple of people in Australia, looking at the optimal dose from studies that have been done, and you're welcome to go down further and further. We have 22 randomized clinical trials where we got all the information from each individual trial. In combination, we were able to look at the individual aspirin doses from those trials, and you're welcome to click down further and further. Please go ahead. And what we did is not only did we look at those individual trials, but we also looked at a randomized clinical trial that was published just a couple of years ago that used a slightly higher dose of aspirin. You're welcome to click through this. Please go ahead. Yeah, and click. And what we have is when the aspirin dose is under 81 milligrams or up to 81 milligrams, which is a baby aspirin, we have them in Canada, we get a relative risk reduction on the top that's about a 10% relative risk reduction. When the aspirin dose is a higher dose, more than 81 milligrams, we get a non-significantly higher improved reduction in the risk. The Aspirin trial is that randomized trial I mentioned a moment ago that was published more recently, where they used 150 milligrams, which is almost 2 baby aspirin. And they suggest about the same 30% reduction in the risk at that higher dose of aspirin. So we're sort of off the fence now and probably thinking at least 81 milligrams and probably 162 or 2 baby aspirin is the way to go. You're welcome to click further. I'm almost done. And for preeclampsia as the outcome here, but not only preeclampsia, but also preterm birth, we can even see a greater in the red improvement in the reduction of this preterm preeclampsia outcome at the higher dose of aspirin. Next, click, please. And click again. Please go on. And so what we really know is the bottom line is that when we have women who we think we can identify are at higher risk of preeclampsia, that we can start at least a baby aspirin every day or every night. We usually say when a woman brushes her teeth, she takes the aspirin. She starts it at sometime between 12 to 20 weeks of pregnancy. She, of course, speaks with her care provider. Next, click. And, we try to start early enough that we think the aspirin will take effect and work the way it's supposed to, like it has been used in the large randomized trials. Next, click. And I know that in bridging to Dr. Cohen's talk, I've talked a lot about pregnancy and specifically aspirin and preeclampsia and growth restriction. But what I wanted to do was to articulate that preeclampsia and growth restriction are two major players in their relation to having a baby who is born preterm, especially when the provider, the obstetrician or family doctor or midwife needs to intervene because of either the poor growth of the baby or because the mother is developing preeclampsia. And now Dr. Cohen will bridge you to much more of the real-life situation of those who are existing parents. Thank you.
Okay, Dr. Ray, thank you so much. I will have some questions at the end of Dr. Cohen's presentation, so stay here with us. And if you have any questions, any comments, please send those on the comments, and I'm going to address at the end of this presentation. Thank you.
Thanks, Fabiana, and thanks, Dr. Ray. So just switching gears a bit. So Dr. Ray spoke about steps that are important to consider for mothers after giving birth to a preterm baby, particularly when there's risk factors related to the placenta in subsequent pregnancies. I'm going to speak about something a little bit different, which is just the general concept of parent well-being, speaking both about mothers and fathers. Next slide, please. So I have some important disclosures to make. I have no financial ones, but I think anytime you hear a speaker, it's important to know what their lens is and what their perspectives are on the topic that they're talking about. So I'm not a neonatologist. I'm a general pediatrician who looks after many children who have complex chronic illnesses. A large part of my practice are children who have been in the NICU, many of whom for preterm birth, many of whom for other reasons, either on top of that or separately from that, like birth anomalies and other issues as well. And I'm very interested in thinking through ways we can improve outcomes both for these children as well as parents and other people who support them over the course of their lives. I think, and I'm going to speak a lot today about mental health as well, which is such a critical piece of this. But I'm not a clinical expert in either prematurity or mental health. So take what I say with a grain of salt. I think that's an important disclosure to make. Next slide. So to begin with, I think it's important to talk about, so when we talk about babies who are born preterm, where do they fit in terms of how we think about health in general for children and how we support families in caring for children. So most children are healthy, and only a small proportion of children have increased healthcare needs. About 10 to 15% of Canada's children have increased healthcare needs. That can be something like a learning disability, asthma, a whole bunch of different things that may need them to require some sort of specialized care from a pediatrician or other sorts of pediatric healthcare providers. And most graduates, particularly those who are extremely preterm, are at risk of some of these things. It's important that we keep an eye on that. The group that I care for in my practice, and the group that I do most of my research for, are those who have complex care needs. Next slide, please. This is a relatively smaller group of kids, but I think it's kind of important sometimes to actually define what we mean by complexity. And I find sometimes analogy is the easiest way to make to try to think through some of these things. So next slide. So sometimes it's important to compare what we mean by complexity as opposed to just things that are complicated. So a smartphone like this one here is an excellent example of something that's complicated. A complicated system is something that has lots of different parts that are connected to each other, but the critical piece of complicated systems is that they're connected to each other in predictable ways. Compared to that, there's complexity. Next slide. So a great example of complexity, nothing to do with preterm birth, or maybe something to do with preterm birth, is parenting. I have 3 adolescent children in my home, beautiful, wonderful children. When they walk down the stairs in the morning and I wave hello to them, I cannot predict what their response to me on any given morning is. It might be a smile, it might be a grunt, right? So there's a lack of predictability in the relationship between components in a system, and that's really the cardinal feature of complexity. Next slide. And when I think about how that applies to parenting and parenting a child who has either special needs or is at risk of having special needs, it's important to think about that sort of thing. I think a lot of the issues and the challenges that come in, that come into play in caregiving and in parenting are due to the fact that a lot of what we deal with in parenting babies and in young children who had preterm birth is this notion of complexity, and that can manifest itself as uncertainty, right? Like the uncertainty of what will come after you leave the NICU and the stress that's associated with that. And it can also be related to the needs of the child themselves. So complex systems can be those that are related to children who have many needs, who have involvement of many body systems as a consequence of their prematurity, who need care from many different providers. And as a family, having to navigate a system that is sometimes quite difficult to navigate because you need to deal with newborn neonatal follow-up, you need to deal with preschool services, need to deal with developmental services, transition to school, many different things that are all interrelated. And the next slide, and these things are often quite intense. Next slide, thank you. They can be associated with disability, they can be associated with medical fragility, they can be associated with lots of different things. And when children have many needs, it can have a huge strain on parents and families. There's lots of data to suggest that families who care for children who have elevated needs are at risk of strains that are both personal and financial in nature. Next slide. And if you actually try to diagramize what this looks like, put a diagram together of kind of what the supports that a family of a child with many needs are, you can quickly see how difficult it can be to navigate, right? This is just an example of one child who has cerebral palsy and as a consequence of prematurity. And you, just looking at this, you quickly see the many different players in healthcare and education and social supports and in the community. And really what it comes down to, the key feature of that causes so much stress is the fact that these kids need care from many different people in many different places over time. Next slide. And the consequence of this is, like, when I teach my residents in the hospital about caring for these kids and their families, sometimes people just don't even have a clue. So just to give you one thing that we do with our residents, we ask them to create a hypothetical visit they have that a family has of a child with special needs coming to the hospital. So an example here is of parents of ex-25-week twins with multiple medical needs who come for a follow-up appointment. And what we make them do is we actually ask them, okay, can you list what you have to bring to the appointment? Right, like, as a parent, my kids aren't young anymore, but even the basic stuff like diapers, wipes, all those sorts of, a secure car seat, et cetera, are the things that any parent needs to consider. But then add on top of that the layer of what of a parent of a child with increased needs. Next slide, and you could see next slide. Thanks. That, like, even just thinking about the equipment and everything like that can be very, very difficult and traumatic for many people. So, lots of studies have been done looking at parent well-being and preterm birth. And I think it's really important to say that there are diversity of experiences that parents have. And that can happen when you're in the NICU, and that certainly can happen after you leave the NICU. And some of these experiences are negative in nature, guilt, stress, challenges with mood and anxiety. And some of them are very happy feelings as well. And I think that's really important to recognize that, the divalent, the two extremes of emotions that many people experience after giving birth to a preterm baby, and certainly when they transition to home after leaving the NICU. So many families obviously feel tons of happiness and great joy in bringing their children home, but some families feel quite a lot of anxiety, adjustments to new roles as parents and as partners after they leave the NICU, ongoing concerns, medical and developmental concerns. And a huge piece that I hear repeatedly from family that is stressful to many is uncertainty, because nothing anyone has ever told in the NICU is certain, right? There are always some level of uncertainty associated with information that we receive or that we convey to parents and families when they leave the NICU. Next slide. And this can have huge impacts, right? So I'm just going to now list just a couple of studies. I'm not going to talk a lot about original research, but just a few studies to suggest the impacts this can have. So this is a study conducted by Krista Kelty in her PhD of families of children who go home with technology. So nasogastric tubes, feeding tubes, oxygen, those sorts of things. And she compared the sleep of the parents who took these children home to parents of healthy children who were the exact same age. And I don't think this will surprise anybody, but it's really important nonetheless that the parents slept much less and the parents slept much more poorly than parents of otherwise healthy children. And she actually did this study. She put actigraphs, so like smart watches, on the parents. They took them home. So actually measured exactly how much time they slept, and they slept more poorly and fewer hours than parents of healthy children. Next slide. And this can have consequences, right? Like this idea of stress, poor sleep, caregiving issues that having to be vigilant, having to be up all the time, looking after a baby can have impacts. And there's actually a study that came out this morning. I didn't put it in my slide deck, that suggests that this is true not just for mothers, but true for fathers as well. And the reason I bring up the gender issue is we know that postpartum depression and postpartum anxiety and postpartum issues are really, really important to screen for. Traditionally, that hasn't been done very well. And there is a lot of work going on now to do a better job of that, particularly for moms. But when it comes to children who are born preterm, it's actually quite an issue with fathers as well. And particularly over time, the mental health impacts for mothers and fathers are actually pretty similar. It can have impacts on physical health and can have impacts on family well-being. Next slide. And this is just an example of one study. And this, I think, is the last study I'm going to show that just shows that this can even have an impact on mortality. And I don't want to alarm people to say that, being a parent of a baby born preterm will increase your risk of dying prematurely. The risks are relatively small, but they are there. And they're true for mothers and for fathers. And the key piece of this is not that, there's a huge risk and we need to really worry about it, but that we need to take steps to really start thinking about this. And as a pediatrician, working in a children's hospital, this is something I spend a lot of time thinking about. We spend so much time focusing on the health of children. And traditionally, we've also spent a bit of time focusing on the health of parents, because we think that when parents are healthy and feel good about themselves, that improves the health of the child. That is totally true. But we also need to think about the health of parents as something important in and of itself, because there are consequences to what happens when we don't support parents and families appropriately in terms of their own well-being. Next slide. So now I'm going to focus on a few solutions and things that we know work really, really well to attenuate, to decrease these risks that I've spoken to about before in terms of the mental health, the physical health, and of parents. Next slide. So to begin with, I think I'm going to just talk about this conceptual model of what improves outcomes in people who have chronic health issues. This is true of babies. This is true of older children. This is true of adults. Unlike in acute care, when you have a problem that is very acute, the likelihood, the outcomes that you have really depend on a few cardinal things that have more to do with the healthcare system than they'd have to do with us as people. So if I'm a patient and I, heaven forbid, have a heart attack, the immediate outcomes that matter, that improve, are based on how quickly I can get good treatment, the quality of the care that I receive at the time. With chronic things, like transitional things, care of children who have chronic health issues, disabilities, things that matter much, much more are actually the bottom of this figure. So it's whether we have productive interactions between caregivers and patients and the team who's looking after them. And to do this, we actually need a community of care. We need a healthcare system. We need supports for that to happen. The example I give is diabetes. So if an individual has diabetes, they can have the best doctor in the world. It doesn't matter. The outcomes that matter are whether they're actually informed about their diabetes, whether they're actively understand their disease, whether they have a system of care, funding supports to get their insulin, to get their supplies, and those sorts of things matter in terms of improving outcomes much, much more than just whether they receive evidence-based care for their disease management. Next slide. The other thing that's very important and is really has a huge role in caregiver outcomes is whether care is coordinated. So one of the things that causes the greatest amount of stress for families, and again, thinking of that example I gave of remembering what to bring to an appointment, is a very small microcosm of this, is whether the care is fragmented or actually centralized. So families feel way more support when they feel they have an individual to go to for their care, and it's not just navigating 20 different subspecialists and therapists and school and social services to try to get the best outcomes for their children. The feeling that they don't have to feel like they're fighting all the time with the system to get the services that they need, but actually have a responsive, organized, coordinated system of care. That is critically important for parent well-being and obviously for the well-being of the child as well. Next slide. And also being attentive to the needs of parents themselves. So all of you who are parents in the audience today, I'm going to talk a little bit about that. I hope you can relate to some of this. The critical importance of feeling strong and confident about yourself and your own well-being in order to provide the best care possible and the best support and the best love for your children. Next slide. And I'm not going to be comprehensive about this because I think you are the experts as parents, but a few things I've learned over the years from working with parents and families. Number one, take care of yourself. So when you go on an airplane, you always remember, that they tell you when you get on the plane to make sure you put on oxygen on yourself before you put oxygen on your child. Unless you have oxygen, you won't be able to help your child, right? So that's true in everything in life, and certainly true in caregiving. Next slide. Sorry. A second piece is seek out support, and lots of parents I've worked with over the years have found that they learn a lot from just finding other peers who've experienced something similar to them. Very common theme I hear from families and parents is isolation. I feel like I'm alone. The people in my community may not understand what I'm going through. So finding other people, like forums like this, where parents of preterm babies get together to learn things together, are a piece of that. But finding other people to provide peer support, I think, is critical. Next slide. A third piece of this is being aware of signs of burnout. And those are both physical and emotional. So I gave the example of sleep. I'm not sleeping well. Why am I not sleeping well? I'm gaining weight. I'm losing weight. I feel more stressed than normal. Being really, really aware of those sorts of things. And us as clinicians have a role to play in that as well. Again, I've become more attuned over the years to actually ask questions of parents about how they're doing. Even though, again, I'm a pediatrician, I think it's really important to at least ask the questions about how parents are doing, because without doing that, we won't be able to help parents, and if parents aren't doing well, they won't be able to support their children. And then the last one, next point, is be able to recognize those signs and find help and get it if you need. And that help can be through your primary care provider, through public health programs like Healthy Moms, Healthy Babies. There's lots of programs that exist to support parents. Not enough, for sure, and most of them tend to be focused in the first few months of life. But I think it's really important to be cognizant when you're not doing well, to find help to support you as needed. Next slide. Another piece we've learned from families, really important, particularly of children who have special needs, is being able to tell their story. So a big stress for many of the families I look after is feeling that they don't have a voice, that every time they meet a new provider, they feel like they have to tell their story all over again. They don't understand them. So we've done a lot of work over the past years in the complex care program at Sickkids to work with families to do something called care mapping. Care mapping is a very simple thing. We ask families to make a diagram of your child, the things that are important in their lives, and how they interconnect with each other. And families draw these care maps in very different ways. Some families draw very medically oriented care maps. This is my child. This is their all the subspecialists who follow them, and this is my doctor here, my doctor there. Other families draw diagrams like this, which just focus on, like, this is who my child is. Happens to be a child with disabilities. And just really who's non-communicative. So it really gives a voice to the child, and allows them to really, anyone who meets them for the first time, to really understand. They love hearing songs. They love being smiled. They love smiles. They love all those sorts of things. You really get a bit of a picture of the child. So we've encouraged families to use these even in communication with providers when they meet them for the very first time. Next slide. And then I'm just going to close on one small study that we have completed recruitment for, and we're going to have some findings for hopefully in the next 6 months, which we've run in the NICU in a number of NICUs in Toronto, in Ottawa, in Vancouver, and Montreal, looking at ways we can support families better after they transition after the NICU. So this is a randomized controlled trial where we randomize families who are leaving the NICU to 3 different interventions. The first one is coaching and support using something called an acceptance and commitment training framework, or otherwise known as ACT. The second is providing them a contact of a nurse who can provide care coordination for them. And a third is some anticipatory guidance and education around what to expect after they leave the NICU, because it's often such a stressful time for families who leave the NICU. And what's unique about this trial is actually the outcomes. We're interested in a whole bunch of outcomes of both the parents and the babies. But the primary outcome, every study has a primary outcome. What is it that you're most trying to change? The primary outcome in the study is actually parental stress. So that's been really, really important for us to focus on in this particular study. And there's lots of other models of things that work that I'm not going to talk about today, but this is just an example of one of them. Next slide, please. And what's unique, I think, about this study is the utilization of this acceptance and commitment therapy. So I'm just going to talk very briefly about it. The focus of acceptance and commitment therapy is mindfulness, really thinking about what aspects of our mindfulness and behavioral change strategies can we utilize to foster psychologic flexibilities. And the way this has been explained to me by psychologists it's almost the opposite of something called cognitive behavioral therapy. The problem of stress when babies leave the NICU is not a behavior that has to change because the behavior is the problem. The problem is that the situation that parents live with, the stressfulness is really, really difficult. So the issue here is not about trying to avoid these difficult thoughts and feelings that are experienced by many families after leaving the NICU, but actually how to better embrace them. That's totally the opposite of things like cognitive behavioral therapy, where parents are trained or patients are trained to avoid things that cause abnormal thoughts and feelings. Here, it's about actually embracing and figuring out new ways of dealing with them. And there's good evidence that it's effective in lots of different populations, including caregivers of children with autism. So we're going to have results of that in the next few months. And Fabiana, if you want to invite me or other members of our team back, I'm happy to chat about that in the future. Next slide. So that's all I had to say. I just to summarize a few things I think that I've learned over the years from parents and families that work about in improving outcomes for caregiver well-being. If anyone has any questions, happy to chat about it, and feel free to email me, and my Twitter handle's there as well. Thank you for your time and attention.
Okay, Dr. Cohen, Dr. Ray, thank you so much for sharing your knowledge. And to be honest with you, your talk about the complex care, and also that is all about my life. I could totally relate it to that. And I will bring a comment here, also from Shireen Fakira, completely related, went home with a feeding tube and a Q3. So thank you so much for joining us, Shireen, and for sharing that with us. But I will start with Dr. Ray, because we talk a little bit about aspirin. I don't know how many people are watching from the beginning of the presentation. And my question to you is, with all those studies that are already done, we have evidence that aspirin can really help with preterm birth and preeclampsia. When is it going to become a standard of care? What do we need to do for this to become a practice in Canada?
Well, it is a standard of care, so that's a great point. Why isn't it a standard of care in practice? Part of it is the simplicity of the moment in which a woman is in her early pregnancy, maybe even before pregnancy, but we'll say in the early part of her pregnancy, and nobody has quite done the very simple thing of calculating in a very simplistic way, like with our circles or some cousin version, what her risk is. And then say, yep, she's at high risk. Okay, here's a handout. Give it to the woman, let her read it for a minute. She can consider it and then decide whether she goes and buys the aspirin and takes it at the right dose. And so the dissemination of that method of identifying her, we've tried very hard, but hasn't made its way into sort of the national focus or the provincial focus if you're in Ontario or in the United States in a similar way. And so that identification of the woman is the principal barrier, not the use of the aspirin or how much to take, and also when to stop it. And so part of this has to do with the inertia of just how clinicians adopt things in clinical practice. And so one of the ways to solve that is to go directly to the consumer, so to speak. You bypass the practitioner, you get to the woman, you make sure she understands her risk and can identify those risk factors, start aspirin and let her practitioner know. That's probably the most direct way to go about this. It's not our favorite version because it, of course, blindsides the practitioner. But a busy OB obstetrics practice often doesn't have the time to simply engage in this very simple assessment. So in the end, automated procedures, artificial intelligence will likely bypass the woman's brain and the practitioner's brain and just get to the bottom line of she should be on it or she shouldn't be because she meets the criteria.
Right, because we did talk with different experts and parents before who had preeclampsia, and this is not a usual conversation that we have on a prenatal appointment, right? Like if you have a early pregnancy and you go to obstetrician, if you are healthy, none of this is brought up. As far as we heard from parents, even myself, I was very healthy. I was high risk because I was 40 years old with my second pregnancy and twins. But even the fact that I could potentially deliver earlier was never part of a conversation. So where we have gaps, right, between the practitioner and the pregnant parent. So how can we try to minimize that gap so the pregnant parent have all that information at hand? Like, okay, I am healthy, I'm 25 years old, but it's still, there is a small possibility or chance of things going in a different way.
Yeah, and we want to go beyond the term small because small is like 1 in 1,000. And we're really talking about small in our case still being sort of maybe about 1 in 20 or 1 in 10. And so that risk, though small, is determinable. You can actually get to those sorts of estimates of risk, the absolute event rate being 10%, not 1 in 1,000 or 0.01% or whatever that is, sorry, 0.1%. And so in that manner, presenting that to this group, who are advocates and experienced individuals with a very tough Italian woman leading the way here, was sort of my strategy as another way of just getting that information out. And yes, I agree at the national or provincial level, wherever you are, that message needs to be made as easy to access, and again, the estimate of a woman's risk as easy to determine as possible. And that's been a slight uphill fight I've had, and why I designed and created the circles, because it's about a 5-second brain maneuver to determine if a woman's in the circle, the green or the orange circle, or not. And a lot of people who are academics get in the way of progress because they nitpick at things rather than go with the practicalities. And so that's why I like sharing this sort of information with practical people who do exactly what you're doing.
Well, thank you. I do hope that people are listening to us, to you specifically, and having your knowledge and understanding the benefits of it, and hopefully many more practitioners will start using and adopting that practice. But Dr. Cohen, let's talk about once baby's out of the ICU, now the baby's in complex care. But before we go there, can you share a little bit about the complex care program at Sickkids? Because for me, when Gabe was out of the ICU, it was a brand new program. And we were part of the complex care, I think, after he was 2 years old. So just tell us a little bit about this model of care and the navigation piece of it.
Yeah, so thanks, Fabiana, and thanks everyone for joining again. So the picture I showed of that tree is in essence what our program's about. We were launched in 2006 because we recognize at Sickkids as a hospital that we did not do a good job of giving people a strong trunk in their tree, and families of children with complex care needs often felt lost in the system, and it was bad. It was really, really bad. It's still a challenge, but I think we've made some progress. So our model of care is families will refer to our program if they meet the criteria for the program, and I can talk about that if that's of interest. Are seen by a pediatrician and a nurse practitioner who provide care coordination for the child and try to create a plan of care to try to streamline services, and so that people who are caring for the child understand what the child needs. So to give an example, if a child has epilepsy, then we will put a care plan that says, if they end up in an emergency department, they should get medicine X and not medicine Y because that doesn't work as well. Like things like that spell out very, very clearly what their needs are in different situations. And we build those together with the families. Over time, the program has evolved. Most of the patients we actually don't see at Sickkids. We have 7 community hospital partners, and it's actually 6 community hospitals and 1 children's treatment center who are partners. And at the moment, we follow about close to 600 children in the province with complex care needs through the Sickkids program and all our associated clinics. And again, the idea being, because our hospital serves a very large part of the province, providing care as close to home as possible. And other children's hospitals in Ontario, McMaster, CHEO, London, have developed similar sorts of programs over time. And our goal, we're still not there yet, but as a province, that every family of a child with complex care needs will be able to receive services like the ones offered through this program. So that's on a high level what the program's about.
Okay, a quick question. Which families qualify for that program? Because I know one of them, as you mentioned in your map, has to be technology dependent. So what are the criteria?
So we have a referral form that's available for providers to refer patients to. And their bar is pretty high. I would actually argue it's too high, but we had to do it that way because there are so many of these children in the province that we wanted to ensure that we were able to at least provide services to the ones with the greatest needs. So at the moment, you need to have a complex chronic condition. You need services from many different providers in many different places. So at least more than one, organization. So an example would be in Ontario, like Holland Bloor Review and Sickkids, right? Would be an example. And then you need to have either technology assistance, so something like a feeding tube or tracheostomy tube or something like that, some form of home ventilation, or be very medically fragile, so that that if some minor thing like a cold happened to your child, it would make you sick enough to end up in hospital. That's a pretty high bar. But even despite that, we still have wait lists. So we've had to do it because that's the only way we could do it with the funding that we have.
And I do hope you can extend that to more, because it's such an incredible model of care that absolutely helps families. And I do hope a lot of other provinces in Canada and people from other countries can adopt that model, because it is really exceptional. And we have a comment here from Lydia. She's joining us from Buenos Aires. Great talks. It's very important to highlight that it's not a one-size-fits-all regarding families with SHCN children. I'm not sure about what that is. Special needs. Okay. So what is the suggestion for public policies? Thank you, Lydia, for joining us.
So I guess that question is for me, although I'm sure Dr. Ray could also give some opinions on this. It's an excellent question. I think the problem, you just hit the nail on the head, right? The issue is we have one-size-fits-all policies. You either meet criteria or you don't meet criteria for a particular service. And often it then ends up becoming reduced to diagnoses, right? We've seen that with developmental services. And I do a lot of work internationally. That's not just true in Canada. That's true in, I don't know Argentina per se, but it's true in many countries in the world. Policymakers like to think of themselves as gatekeepers. And they're like, we need to put a gate up, and we need to make the rules as simple as possible because it's too difficult to otherwise adjudicate. And what ends up happening is sometimes it actually creates just bureaucracy, frustrates families, and doesn't actually get services to the people who need them the most. So I think where we need to start moving towards, and we're starting to do this in some jurisdictions, is actually using voices of families to understand what needs are and focus policies based on needs and not just artificial criteria of you either have a diagnosis or you don't have a diagnosis. If you're 26 plus 1 days, you don't meet criteria. If you're 25 weeks plus 6 days, you do meet criteria. Like those sorts of very artificial barriers that aren't focused on needs, I think end up causing more problems than they're worth.
Absolutely. So we have one more comment here from, let me find here. Oh, that's absolutely true. Thanks for the answer. But we have a comment here from Sarah. I find it so hard because we're often repeating our story with every specialist we see. It is as if healthcare is like multiple silos rather than one open umbrella. Sarah, I can totally agree with you because I've been 9 years into the system, and I cannot even tell you how many times I've shared my own story. So, Dr. Cohen, how do we help families with that? Because I have to be honest with you, just last week I had an appointment for a consultation for a surgery, and we are in university hospitals, right? So we see the resident, second-year resident, and she wants to go over my son's history, 9 years of history. And I had to take a deep breath because I'm exhausted telling stories, his story, his medical history that is in front of her in the computer. But I also understand it is a university hospital. But how can we help families not to get overwhelmed? Because it is an overwhelming process.
Yeah, Ian Brown, who's a reporter for the Globe and Mail and has a child with special needs, said, I quote, "This is what makes people yell at receptionists." That really, I find that very poignant. I think the advice I give to families and things we do in our program, whether you're in a program or not in a program, is it is worth the effort to put in writing your story, be it by a care map or by a care plan, like a one-pager that says, this is Johnny, he was born in 24 weeks, he has, chronic lung disease, all the issues that he has, he's on these medications, he receives these services. And when someone says to me, tell me your story, just give them a piece of paper and then say, what questions do you have after you read? So I think empowering people to say, to hold providers accountable for the fact that we're busy, et cetera, we are, but we have a responsibility to read charts. To defend us, our charts are totally disorganized and all over the place, so it doesn't make it easy. So the only thing I could advise, I say this to providers and I say it to families as well, is do the best you can to summarize information, to make it a little easier for the providers to read your story, and to make it less frustrating for yourself to feel like you have to tell the story over and over and over again. So that's what I think of care plans as. They're like medical passports, right? Like this is my child's story. And if you need any other details, ask me those questions. But it begins, and those care maps, those pictures that I showed also help a little bit, because it makes the providers take a step back and say, whoa, there's a lot going on here. I'm not gonna, some of this information I'm asking for may not actually be that relevant to what the concern is today. So the more of that we do, I think the less frustrating these encounters would be.
And my quick comment on that is, in keeping with Eyal, if a parent can get a USB stick to go into a computer, then it's in their best interest to have on that USB stick a Word document that has the past medical history of the child, because we also do this with adults. I also do adult care. Past medical history in number form, probably in a either time-based order from the earliest period of their life to the most recent. You can take something out of the list if it's no longer active. The second is right below that to have a careful list of all the current medications, and simply to update that before an appointment, because that USB stick can stick into most computers and be opened and then pasted into the current record, if it's digital at least, the current record that the practitioner is using in front of them, if they don't have the updated version, because it is not fair that you have to tell your story over and over again. And in fact, it sets up for more errors than continuity. And so that's in the best interest of everybody. The obvious thing is to have a constant digital record that transports across a province or a state that can't change except by very specific change options. But in the meantime, the parent can bring that vehicle with them in addition to the visual care map that Dr. Cohen describes.
Absolutely. I think those are great suggestions. And I do love the care map, because also when people look, I feel we build some empathy and compassion, because, okay, my life is overwhelmed. So I go to all these appointments, everybody gives me a little bit of homework or things to do. So it's really put everything out there. This is how overwhelming my life is, which leads to my next question in terms of mental health. Wow, I cannot even tell you the sleep deprivation, what causes, obviously, to families. My son didn't sleep for 4 years and I was exhausted. And all those years, nobody actually asked how I was doing. So I have a comment here from Shing. Really, thank you for asking the parents how they are doing, because sometimes that's all we want, somebody to acknowledge that, yes, we are also not in our best, because there's a sleep deprivation, constant worry, the unknown ahead of us, really. And especially if you come from a medical condition during pregnancy that Dr. Ray was talking about, pre-eclampsia, you already suffer your own physical issues, and now you have to deal with an ICU, and then you have to deal with further diagnosis after discharge. So I think all that adds to the pot, because nobody, I think, arrives in complex care from a very easy ride. I think there was some bumps along the way from the time we land in that new universe. So I absolutely love the fact that you say, what can we do as a community? And my question is, how can you think about this together and support families? There's so many research showing the impact on mental health for families, but what are we doing to really support the parents of kids with complex care?
Yeah, so I can talk about our program. We are experimenting, that's the wrong word. We are piloting, I'm a researcher, so I use the word experiment, but I mean piloting. We are piloting what's called a stepped up mental health strategy for our program, where we screen, we ask questions, how are you doing? We do preventative stuff, peer support programs, well-being. Before the pandemic, we had an overnight camp for our families to come to, which was amazing. I was there. And then
may I interrupt for just 2 seconds?
Sure,
I apologize. I do have to get going. I'm needed in the hospital, so I apologize for kicking off.
Doctor,
Sorry,
thank you so much for joining us.
Thank you, Fabiana. Yeah. Good day.
And then on the intervention side, so we have social workers in our program who can provide some therapeutic support, and we are piloting actually having a psychiatrist in our program as well. And this may sound simple, but it actually isn't that easy to run, because this is like, I'll give you the simplest thing. Like, how do you register a parent at Sickkids at a children's hospital for care? Do you make a chart for them? Like, once you start getting into these issues, there's some complexity layered on. But at the end of the day, for me, the key piece is we have to stop differentiating health of child and health of parents. Those are two separate systems. You have an issue as a parent, go see your family doctor. You have an issue as a child, we'll take care of you in our children's hospital. I think we have to stop. And there's a reason children's hospitals were created. They were created because we do things differently, and children are different, and children aren't just little adults, and they need special services and special supports and special training. All of that is true. But I think it's kind of gone a little too far. And now that, most of what we do in children's hospitals, caring for children with complex needs, and doing really complicated things in their NICUs and in our transition out of the NICU, I think the time has come for us to really get together with our adult healthcare partners like Dr. Ray, and begin to think of strategies together on how to best support families.
Wow, you made my Friday. I feel like this is truly a hope for the future for families with complex care kids. Wow, I really appreciate that. All the work that you do, looking into the parents' health and well-being. And I really love the CSENT project. We actually did a talk with the researchers in January. So it is recorded, it's on our website. It's such a fantastic program. And I do hope many NICUs will adapt to that model of care, because it's so great to have that support for families during the transition from the NICU to home, and give those strategies for coping at home. This is incredible. But Dr. Cohen, thank you so much for your time today. I could be talking to you all afternoon, but you really gave us so much hope that the families is a one unit. You're looking at the families as a holistic approach, rather than this is my child, that's the piece of the child, and here is the parent. So I really appreciate the fact that you're looking into the whole unit of families, because we know all the problems that families can have by having a child with complex care. So we have a comment here, last comment from Suk. Absolutely agree. So thank you so much for joining us. And Dr. Cohen, thank you.
Thank you, everybody.
So we can continue our conversation and bring more light into this world that we're living in right now. Thank you.
Have a wonderful weekend, everybody. Thank you.
Thank you. And for all of you watching us live from Facebook or YouTube, thank you so much for joining us here today. The video of today's session and all the other videos from our live series are available on the CPBF website, which is right here, the CanadianPreemies.org. We are a charitable organization, and we believe that through education and support, we can empower families, ensuring they are ready to care for their premature babies. Visit our website, consider making a donation. I truly believe that together we can create a brighter future for all our families. And I want to thank our sponsors, AstraZeneca and Water Wipes, for their continued support to our education sessions. So I stay well, everyone, and I see you again next Friday, 1 p.m. Eastern Time. Thank you.